I'm Dove Sachs. I'm the interim director of IBIS, which is the Institute at Brown for Environment and Society. And I want to welcome you today to our joint seminar between the School of Public Health and IBIS. This is the third in our series looking at the intersection of climate change and health. I'll just briefly mention a few things. I'll tell you that IBIS is an interdisciplinary institute with a real focus on climate change and expertise around sea level rise and change in the Arctic, conservation, conservation of species, and an interesting sort of expertise in studying how the climate misinformation campaign is funded and works, as well as other social science. I'm delighted today to be able to say hello to you and tell you that we're excited to build the expertise of Brown around climate change and health. I'm going to turn it over to Dr. Ashish Jha in 1 minute, but I just want to mention two little details. One is that this is being recorded today, so it'll be available for later viewing. And the other is at the end of Dr. Kovats' talk, you can ask questions by typing them into the Q&A box. And we'll get to as many of those questions as possible. So now I'll turn it over to Dr. Ashish Jha, Dean of the School of Public Health.
Yeah, so Dove, thanks, and good afternoon, everybody. Thank you all for being here. Dove and I, a few months ago, in a series of conversations we were having about what else or what should we be doing on the intersection of climate change and public health, decided that we would jointly launch this seminar series. Obviously, this is just the beginning. And I'll say from the public health perspective, from the public health side of this equation, to the extent that there's an equation here, climate change represents one of, if not the biggest, public health threat of our times. It is not a threat that will arrive in 20 years. It's not something we have to think about for the future. It is here, it is now, it is happening. And the ways in which it will stress public health will get worse over time. And while there's a lot of work to do on dealing with the underlying issues of climate change, energy policy, and obviously decarbonization, and things that are very, very important, and in fact, at the heart of combating climate change, what we at the Public Health School need to be doing, and what we in the public health community need to be doing, is thinking about the impacts of climate change on public health, on the health services, on health and well-being. And that's the goal of this set of efforts. And the idea is we start here, but we have a lot more work to do, both in education and in research and then in policy translation. So when we sat down and came up with our kind of dream team of people we wanted to have join us to talk about these issues, our next speaker was on that very short list of people we really wanted. So let me tell you very, very briefly about Professor Sari Kovats, who is at the London School of Hygiene and Tropical Medicine. So most of you know LSHTM. If you don't, it is one of the premier public health institutions in the world and has been at the forefront of this, maybe more than any other school that I can think of, anywhere in the world, in terms of, and when I say this, I mean climate and health. I've really been doing extraordinary work as an institution with a whole bunch of great scholars. And so let me tell you just a little bit about Professor Kovats, and then I'll turn it over to her. She's an associate professor in the Department of Public Health, Environments, and Society. And she leads a series of different major projects funded by NIHR, which is the NIH equivalent essentially in the UK, looking at environmental change and its effects on health. And she has been also leading some really important work on heat and maternal and neonatal health outcomes, and has been doing work to try to link what happens in public health with what happens in health services, with the National Health Service as well. So I can keep going, but I'm not going to because we really want to hear from her. So Professor Sari Kovats, thank you for joining us this afternoon, late in the day in London, and I will turn it over to you. Thank you so much for being here.
Is kind of give us a snapshot of the work we've been doing in the UK, both in research that's feeding into the broader climate change sort of risk assessment process, but also what we've been doing in our kind of funded unit. So a lot of the research that I'm showing you is what we've done on this under this thing called the Health Protection Research Unit in Environmental Change and Health. So I'd like to think that this, well, I would like, actually, I hope it's not the only one, but it might have been the first one. The first kind of dedicated research unit within health protection that is looking at environmental change issues. Hopefully other ones have now been set up, so I'd be really keen to hear about those if you know about them. But it was funded by the Department of Health. There were a whole other set of health protection units looking at a whole range of health protection issues. And there are other ones within looking at environmental issues like air pollution, but ours is the one looking at environmental change, predominantly climate change, but not only. So we're also looking at land use, urban issues, urbanization, and biodiversity, sort of green space, green infrastructure, that sort of thing. But the important thing here is it's a collaboration between the universities, so that's us at LSHTM plus UCL, which is University College London, and also the Met Office for obvious reasons, with Public Health England, which is the public health agency. So we work strongly with them and for them, so they can tell us what their evidence needs are, and then we can deliver this hopefully successfully. So a lot of this research is actually work directly for Public Health England as well, because they're the main kind of well, not the implementer, but they provide guidance for implementing actions for dealing with extreme events, for example. So for the outline of my talk, I'm going to try and put things in context, particularly the kind of UK policy context for climate change and health and where public health fits within that. Then talks about some examples for heat and flooding, which is really where my own research lies, and then link that back to how we're kind of managing climate change and how the risk management, where we are at the moment in terms of assessing risks. So I'm not going to talk a lot about how the climate changes per se, other than to say that it's obviously happening a lot faster than perhaps we anticipated. I have been in this area for quite a few years now, and we really at the beginning thought that climate change was still going to be in the distant future, maybe not worry about it until maybe even mid-century, but that's clearly not happening. We've had some extremely hot years. Countries have experienced some extremely awful heat waves, including the US, and also intense rainfall. We can already see these patterns already occurring, and very intense rainfall that can lead to flooding. And we also consider the changing in seasonality and other things that we can also detect. So but there has been a progression, okay? We've made huge amounts of progress from kind of realizing climate change affects health and kind of mapping and modeling those risks, mapping them far into the future, to looking about how we do manage those risks. So looking at what we would call public health interventions, and then evaluating those interventions. This is where we are now within the HPRU. We're evaluating them, process evaluations, outcome evaluations, considering the cost effectiveness under various scenarios. So economic analysis is very important. It always has to be within decision making. Considerations around behaviour change, as well as changes to infrastructure, and also the equity implications of these different strategies. So we're looking at that, for example, in the context of flood responses. Some of those clearly have the potential to increase disadvantage. I'm not going to define adaptation or resilience because I don't think you need to. I mean, adaptation is clearly around managing climate risks. So whatever you want to call adaptation, you can call adaptation. And there are very useful frameworks like this one from WHO about operational frameworks for climate resilience health systems, quite high level types of strategies here. But what we're trying to do, as academics, is try and provide the evidence base so people can make those decisions and put in cost-effective interventions and understands what needs to be done now and what needs to be done maybe in 10 years, or what decisions you have to take now and what decisions you have to take in 10 years' time. But what are health systems adapting to? We have a lot of information now about what the types of risks, better understanding of what those climate changes that we're actually adapting to and what that means in terms of health system planning, health infrastructure planning, managing what we need, particularly for around surveillance, for example, because there's a lot of shifting vectors, shifting people, shifting pathogens, changes in behavior. And then also looking at these upstream issues around failures of critical systems, particularly water and energy. We know that there's not a lot of resilience in some of those systems as well. And there's not a lot of resilience in the health system. I mean, let's be fair, these, especially in the UK, and especially now under the pandemic, they are working at flat out at full capacity. So if you want to make an argument for people to change their strategy or invest in a new intervention, then you really have to make a very strong case. So my other main point I just want to say is, adaptation, a lot of the adaptation discussion is really around things we're very familiar to in the world of public health. Our adaptation strategies have to be evidence-based. All the things we've been taught as public health students, we have to consider the governance of these types of strategies. And there's a lot of good research looking at governance of climate risks. They have to also not increase inequalities. We must consider the equity issues of them, and we must consider obviously their value and effectiveness. And where we can, they need to be designed with the users or the stakeholders who are going to use these strategies. And of course, it's worth mentioning that a lot of the determinants of risk, or the wider determinants of climate related risks to health, are outside the health sector. So we need to engage with other sectors. And I'm very fond of this health in all policies approach that I'm sure you're all familiar with. So for the UK at least, there's a big focus on spatial planning. How do you get health information to planners? How do you get health information to people making decisions around housing or housing standards, transport and water resource management as well? And even within sort of classic disaster risk reduction, there's huge potential for health issues to be considered better. So I'm just going to briefly review where we are in the UK in terms of policy. So the UK is not the only country to have a climate change policy or climate change legislation. And there's some very good websites to see where we are, but lots of countries now have climate change legislation. The important thing that we have legally binding targets, and we have the carbon budget, which is an excellent way of delivering these messages to the decision makers. But there's a strong component of adaptation as well within the Climate Change Act. But it's important to note that that's actually led by a different department. That sits within the Department of the Environment, DEFRA, whereas BEIS, Business, Energy and Industrial Strategy, is responsible for emissions. So there's already kind of a little bit of a disconnect there. And importantly, we have this Climate Change Committee, or the Committee on Climate Change. No, it's now called the Climate Change Committee. They changed their name. But they are an arm's length body, and they have an extremely important role in monitoring progress. So they monitor progress on emissions, and they monitor progress on adaptation. And they're the people who also run this risk assessment. So I've been involved in the risk assessment as a researcher, because that's the science bit that feeds into a science policy cycle. But it's sort of managed at arm's length by the Climate Change Committee, and then they take the report and then they present it to Parliament, and it's accepted by the UK Parliament, hopefully. So you can see the cycle here. We're actually on the third iteration. So there was a CCRA published, so that's a climate change risk assessment. So that's across all sectors. So it covers the natural environment, infrastructure, business, health, communities and the built environment, which is a chapter I contributed to. And also international risks, so how risks outside the UK will affect us within the UK. And it's for all the UK, so it includes Scotland, Wales and Northern Ireland. And that feeds into the policy, which is the National Adaptation Programme. And although that doesn't have a statutory sort of responsibility to adapt, it does declare, or it does set out how public agencies, so not everybody, just the public agencies, need to respond to climate change. And then the Climate Change Committee asks them to monitor. So there's a monitoring progress, which is just as important. So I'm going to give some examples of the research that kind of fits into the climate change risk assessment, because I think it's very important to understand how these big questions, it's a huge question, how will climate change affect the UK and what should we do about it, that you can break it down into sort of your manageable, researchable chunks. So as I've said, the way they cut it up is they look at the decision-making period. So the next NAP basically only looks at decisions you need to make between 2023 and 2028. But that includes managing risks, but within that period, and also where you're locked in or whether any long-term decision makings. So housing, you have a lock into housing. Housing turnover is about 100 years. So you need to make decisions now for how those houses in the future that we will be living in when we have more climate change. So this is the exam question. So it's essentially a review. You can't do a systematic review, but you'll use systematic reviews within a larger review, but you're doing a lot of synthesis, and it's broken down into different risks. So there's a risk on infectious disease, and there was a specific risk around health and social care delivery. But you look at current risks, future risks, and then you look at adaptation. So what's being done now, and then what needs to be done as well. And this is the result from the previous risk assessment. So they're often scored, or they are scored. So where the Climate Change Committee says more action is needed, then there has to be a response about how that risk is going to be managed. And that those actions are what is described within the National Adaptation Programme. But you can see health features quite prominently. So flooding and risk to health are kind of high priority risks. And that's not just because of the magnitude, it was because the evidence showed that these risks weren't being managed sufficiently. Okay, so there's two aspects, the magnitude of the risk and whether it's being managed at the moment. And so things like water shortage and natural capital, some of those risks are likely to be much more pertinent towards the mid-century. So they weren't quite as scored as urgent. So the other thing we have is national projections. Now I know the US also has a national assessment as well, which is a very huge undertaking, and I think you're currently in that cycle maybe. And we have national projections, so it's very important that there's an understanding of how local climate risks will evolve, and that includes sea level rise as well. But the climatologists still have quite a long way to go to provide a lot of evidence that's really useful. You know, like they wouldn't actually tell us what kind of future heat wave risks are like. You have to still do a lot of that analysis yourself. They can't tell us a lot about storms or very extreme events, for example. But we do know it's getting a lot hotter, and we do know, as I said, about extreme rainfall and other risks. But local information, I think, is extremely important. But there's clearly a resource issue, so there's quite a limit to what climate information can be supplied. But all impacts are local, and particularly the risk assessment goes into quite a lot of detail about coastal risks, where local information is extremely important. So as I've said, when you break down the risk assessment into these particular questions, then they become much more answerable. So what's the current impact? Now, a lot of that depends on how good we are now in reporting the health impacts of current extreme weather. So for some outcomes, this is much easier than for others. And there are still gaps in the kind of routine or public health surveillance systems that we have to let us understand how we understand the current burden, particularly at the population level, because, you know, there's obviously case reports, but even then it's quite a hard job to put all that sort of information together. And in terms of damage to health systems or damage to hospitals or loss of services, that sort of information is also not routinely collected in a way that you can usefully say what you know what the current burden is, for example. So I'm just going to go through some research on heat waves. Now, I know your speaker last week went through a lot on the epidemiology, presumably, of high temperatures, so I'm not going to try and avoid repeating that. But heat is quite an interesting exposure in that it affects lots of different things. And what we've had in the last few years is people looking at quite a wider range of outcomes beyond the acute mortality response to see what the burden is. You know, we do have a project on maternal health, so there's a lot of uncertainty actually about what the risks are to pregnant women. And particularly we're looking in Africa, where it's obviously much hotter. Women are also working probably quite hard in the heat, so what those sorts of risks are. But we have a better understanding around the clinical, you know, kind of identifying high risk people and how you target those high risk people when you have a heat wave is still quite problematic, or it's difficult. If you look across what people do across Europe, where every country in kind of Europe has some sort of heat wave action plan, There's very little done in terms of active targeting of individuals. There's a lot of kind of passive communication. But we know people with diabetes, with kidney issues, people with musculoskeletal issues, these are all high risk. So there's a lot of work that could be done to basically mainstream heat risk management within their chronic disease management, I think. There's also been a lot more work around, well-being and thermal comfort, but also cognition. So at higher temperatures, the risk of accidents increases as well. But also children. So schools overheating is currently a problem in the UK. I mean, we have very low levels of air conditioning in houses and in schools and in hospitals, actually. So we have had real problems in these last 3 heat waves that we've had. And the last heat wave, so we've had heat waves in 2018, 2019, and 2020. So the 2000, and we have a good surveillance system now. So post 2003, where there was this big heat wave that affected Europe, Central Europe, especially France and Italy, had a massive impact. And that was the trigger for the implementation of all these heat wave plans, and including the UK got one in 2004. And now we have our enhanced surveillance. So the mortality, there's extra surveillance for deaths. We don't have it for the other types of outcome. And in fact, the impact's generally bigger in deaths than in other outcome like hospital admissions as well. But the heat wave in 2020 was moderately severe. As you can see, there were three kind of hot episodes, but the mortality was obviously very high with this 2,244 deaths compared to like 800, 900 deaths. This is England in the previous heat waves, because we were in lockdown. So people were indoors more, but also high risk people were indoors more. So there's clearly a combination between, a climate risk and another risk. And those sorts of things is what we need to understand. I should say research is ongoing, so we don't actually have the full picture yet about what, who was most at risk and where those deaths occurred as well. Because people's behaviour changed last year, their health-seeking behaviour changed. So people weren't going to the hospitals at that point as well. So there was a lot of interesting kind of epidemiological issues going on. But there is actually a seminar tomorrow run by IAMFI, which I can put in the chat, which is about the lessons learned between managing the heat wave risks in the pandemic. And there's some speakers who've been from France and the US from CDC, who are basically communicating the lessons learned about how to improve your heatwave guidance so that you can take COVID into account. Now, heat-related mortality is very well modeled. So you can see clearly here on the left, we have an increase in heat-related deaths. That's a fairly robust finding. And then a decrease in cold-related deaths, and the cold-related deaths are much bigger in terms of absolute numbers than the heat-related deaths. But you still need to manage both going forward. And that of itself is often quite a difficult thing to communicate. There's a lot of work around cold and there's a lot of work around heat, and you have to keep those messages going and hope that they don't get confused by these climate change messages saying that we don't have to worry about cold anymore, for example. Well, that's the message we got from a lot of stakeholders. But as I've said, we're very interested in the factors now about risk, because we want to know who the high risk individuals are. And there's been a lot of work done around indoor exposures, and then factors that affect your susceptibility, which would lead to which is basically your individual factors like your age, or if you have a health condition. But there's also factors around seeking treatment as well. And whether it was the pandemic that affected people's behavior, or previously people don't recognize heat risks. So we know from France in 2003, a lot of people were becoming ill and they just didn't recognize it as a heat problem. And we think that's probably still a problem in the UK. But what we're trying to do is also identify not just individuals at risk, but kind of locations at risk. And this is a study that we did in London, where we had a very high resolution data set, basically looking at land use types and seeing whether basically living in a green space reduces your heat risk. Okay, so you also have age and gender, which is a factor, and living in a green space. But these effects are not strong. I think you can see that. So we're looking at the kind of best versus worst quartile. We looked at the natural environment, the built environment, and also employment. And none of these factors are hugely predictive. And we know from other studies where they've looked at kind of vulnerability and mapping, it's not a strong predictor of heat-related risk per se, which means that you need to take that into account when you're planning your heatwave response. But other work within the HPRU has looked at outdoor temperatures, and this is from Birmingham, which is a city in the middle of England. And they've qualified the benefits of specific interventions for cooling. So the benefits of painting your roof white, for example, white roofs or green roofs, and how these might, how the quantified the benefit in terms of basically mortality avoided. And then we've looked at outdoor temperatures, and then we had another project that looked at indoor temperatures. So this is a mapping of overheating risks. It's taken data from a housing survey and then looked at, you have models, individual models of housing, building physics models essentially, so you can estimate their overheating risk. And in an average summer, about 20% of houses in the UK overheat, which is quite a lot. And we don't anticipate a major uptake of air conditioning at the moment. But there are other measures, so passive measures that are needed for cooling. And there is a cost benefit that they have now done to show that in fact shading or just adding shutters is the most cost effective and efficient way for reducing heat related mortality. And then another research, just to finish off the heat wave, is there was an evaluation done. So we'd had the heatwave plan for England had been in place since 2004, and it's regularly updated as it should be, using epidemiological information and other information. And then we did some work around risk communication as well, because it's very difficult to communicate around risks, around heat, particularly if you're communicating vulnerability. So a lot of older people don't see themselves as vulnerable. They don't see themselves as frail. So if all your messaging is based around you're frail, you're vulnerable to heat because you're old, then that messaging has very little traction. But they interviewed residents, you know, the general population, and they also did some qualitative research with nurses. So they were looking at the implementation of the heatwave plan. And there was some, as other studies have shown, actually, there was very little, relatively little awareness amongst the frontline staff. So the messages weren't communicating down. It's a cascaded type of warning system. So although managers or senior managers were perfectly aware of the plan, the frontline staff weren't that aware of the plan, but also sometimes they weren't sure what to do, because basically if they were in an overheated ward or an old building, there was limited options for them to deal with the heat stress anyway. So I'm just briefly, I've got 10 minutes left. I'm now going to talk about flooding, because flooding is a key risk also for the UK, and it has quite a range of impacts as well, both these acute ones and then the longer term ones around costs and also around mental health. But there was actually relatively little research on mental health and flooding. Most of the research is actually done from the US and is linked to tropical cyclones or hurricanes. So a huge amount of research done following Katrina, for example, but nothing, relatively little about the kind of more moderate flooding that we were dealing with in the UK. But Public Health England, in partnership with the universities, undertook their own study. So we had some major floods in the winter of 2013-14. And we designed a questionnaire using kind of standard tools. This just shows future risks of flooding, obviously increasing in the UK. Double designing the thing. So we undertook a survey basically and mailed the questionnaire to everyone who was flooded, and also people who weren't flooded because they were our control population. And then we did a second survey up in the north, where there was another flood in 2015, and we used validated instruments to check for mental health, anxiety, depression, and also PTSD or probable PTSD, and also some quality of life questions. And what we found was quite a significant impact on mortality. This is just the prevalence, but the yellow group is the flooded population. This is 1 year after flooding. And then the effects are still there 3 years after flooding. So these are kind of serious conditions. The prevalence is pretty high and they're quite long term. So that has kind of major implications in the burden of disease. And we were also able to look at other modifiers as well. So this is, for example, looks at insurance. So this sort of information is very useful for planning for interventions as well. So we know that uninsured people, or being uninsured, obviously contributes to the mental health impacts of flooding. And also the other, I guess the most important outcome of this study is that the way flood measures are put in is there's a lot of cost benefit analyses that are done. And this is again through the Environment Agency, which is part of the Department of the Environment. And previously they were just making some estimated damage costs around deaths. But deaths are very few, but the deaths weren't even, they were making some assumptions around deaths linked to building damage. But what they've now done is they've now taken into account the mental health impacts of flood events, and that is now included within their cost benefit decision making, which has important implications for future planning. This is another study that we did also looking at displacement. So the histogram on the left you can see is that a lot of the population were displaced for quite a long amount of time, for several months. And we found that the people who were displaced had worse mental health outcomes than people. There's still people who were flooded, but people who weren't displaced. And having a lack of a warning was associated with worse outcomes, but the length of displacement wasn't, for example. And then we're very much interested in implementation. And again, we found a huge, well, there's a big lack of information about how health systems particular are coping with flooding. So we undertook a qualitative assessment within Boston, which is up in the northeast. And they had a kind of near miss flood event. So there was quite a concern that there would be a very major flood, but the wave height and the high tide didn't coincide, so there wasn't a major failure. But that again included some really important and very practical lessons around how they manage flooding, and particularly the work between different agencies and how they work together and how they understand the flood warning. So again, all that information was then fed back to the emergency planners and the health systems to try and improve flood risk. And since then, we've also done well, our colleagues have also done an in-depth interview to look at how the heat wave affected responses and healthcare delivery itself in the last year, in the 2020, and that's in the process of being written up. So I just want to say a few final words about how we might pull all this together. So I think it's very important to kind of gather the evidence base around specific responses. So what is the effectiveness of the current interventions methods? What's the effectiveness of early warning systems? Because there's a lot of interest in implementing early warning, but these things need to be carefully evaluated, both in their kind of predictive value and in their response, so how they're actually implemented in the real world. We also need to think about co-benefits and harms, because especially adaptation outside the health sector is likely to have quite a lot of implications for health. And then we can understand and operationalize these very low cost or no regrets options. You know, things like green infrastructure obviously have multiple benefits, so they're fairly low regrets and also fairly low cost as well. But it's important, again, to understand sort of effectiveness of adaptation. You know, within, you have to specify your criteria. So effective within over which time period. A lot of measures that are effective now aren't going to be effective under future climate change. You know, a lot of the housing interventions are not going to be effective if we have very high rates of warning, because then you will need to introduce air conditioning, and you will need to introduce air conditioning more in hospitals. And how can you do that safely and effectively? And generally, as I've kind of hinted from the flood study and also the heatwave study, we still have a very big gap around how we're failing to learn lessons from recent events. So we haven't got a good mechanism still on understanding what responses were undertaken in response to a extreme event, how effective were they, and communicating that to improve the planning for the next event. And that's true, you know, for the UK, and it's true for many other countries as well. But the other thing is to kind of consider adaptation in the context of other things that are happening. Okay, so a big thing that's happening, as I've said already, is the COVID pandemic. And it's very important that we learn lessons, or those lessons learned from last year can be translated to next year. And as I've said, there's a webinar on this tomorrow. But there's also this kind of an information sheet from the GIM, which is the Global Health Information Network, which I'd encourage you to look at as well if you don't know about them. And WHO has very recently updated its evidence around heat risks as well. And at some point, WMO will be updating this heat health guidance, so that's also in the process. So as I've said, the way that the UK Climate Change Committee prioritizes adaptation actions, because that's clearly quite a tricky process when you have a multiple range of things that could be done or should be done, is that they prioritize things with low or no regrets. So it's important to quantify those health benefits or those co-benefits. And as we know, when there are co-benefits to health, those co-benefits can potentially be quite large. We must factor in lock-in. So again, we must focus around some of these decisions that, or avoid these decisions that lock us in. So focus on the built environment, particularly decisions around housing, quality of housing and planning. And we must prepare for long lead times. And so there's a little bit of work done around adaptation pathways, you know, decision pathways, you know, what points do you need to make certain other decisions. The other thing we also need to take account of is mitigation. And, you know, the UK now has some higher targets even for net zero, and the NHS itself, so the health system, also now has a net zero target. Many local authorities have net zero targets. So there's a huge push in the UK and elsewhere to implement strategies. And a lot of those strategies are relating to kind of housing at the moment, particularly energy efficiency within housing, much stricter controls about ventilation and insulation. And that of itself has a risk to health from reducing air quality and the risk of overheating. So clearly those policies all need to be aligned. And there's been a lot of work now to understand how to design houses that do not overheat but are still energy efficient. You know, some of that is a technical problem, but there's also a kind of a governance issue, and to make sure that rules and regulations and building standards do take everything into account. So particularly when a lot of changes are required, because you also need to modify your house to deal better with flooding, that can be done in a more integrated way. So the building standards in the UK currently don't take overheating into account. That is still under discussion, and we're still hopeful that those decisions will be made fairly soon. But there are a lot of other there's a whole list here, I don't know if you can read that table, of interactions between adaptation and mitigation. A lot of it is synergies, you know, they're all win-wins, but, you know, particularly improving diets and things. But there's clearly conflicts, and we do have to recognise those. So just to conclude, climate change is unavoidable. And I feel that adaptation, we need to basically improve our evidence base for adaptation. We need to make sure that we get local information and involve local stakeholders. And we need to better understand our responses to extreme events. Thank you.
Oh, that was wonderful. Thank you.
On time.
Yeah, and on time as well. Yeah,
amazing.
Fantastic. So, yeah, I really enjoyed that. And we've got quite a bit of time for questions. So go ahead and type questions into the Q&A. So I'll ask you this first question. It's from Dr. Elizabeth Fussell.
Okay.
And it says, this was an excellent model of how a national government can plan for climate change. To address equity issues, it is very important to distinguish between protective actions that rely on individuals or households to take the initiative and those which are undertaken by the municipal, provincial, and national governments. System level changes are arguably more equitable than those that rely on individual action and behavior. How have equity issues been incorporated into UK government policies?
Ooh, that's a big, well, they are. Well, the first thing is that there was a trend of government to shift some of the responsibility for adaptation onto individuals and households. That's what we were, we're clearly recognizing here. So a lot of some of the flood management was around property level resilience or property level protection, and the same with housing, in that people have to retrofit their own houses because building standards only apply to new housing anyway. So these are relatively costly, okay, or you may spend a while to get the benefits back, especially if you don't get flooded anyway. So yeah, so you're right. So to the extent that policies or responsibility is shifted onto individuals, there's clearly huge potential for them to become inequitable, right? And there's nothing explicit on that at the moment in policy, but I think because we've had terrible inequalities shown through the pandemic, particularly certain groups suffering very badly within the UK, there is a renewed focus on inequality. And our chief medical officer has just done he does an annual report. His annual report is on inequality now, and I think they're including some of the climate change stuff within that. So I'm quite hopeful that things may change, that there's a general push. It's obviously not just climate, to make sure interventions improve inequality. So I know there is some work on that, but I don't know where it is, so I can't, but I'm optimistic.
Well, it's encouraging to think that it might be built in and that people are advocating for it at a high level now. So, I myself was very curious to see the projections you had on the difference from changes in heat between increased heat deaths versus decreased cold deaths. And you showed a figure that projected out to 2080, where I think there was maybe, I was sort of curious to see this threefold difference, basically, like for every death saved from it being warmer in the winter, there were 3 more deaths in the summer, something like that. Could you walk us through those findings, or tell us, or maybe I misinterpreted? Tell me what that was showing us.
Well, there's an increase in heat risk, and that it assumes no adaptation. And then there's, current heat risk is not as big as the cold risk. So the UK has a particular problem in cold because we have very poor housing quality, and there are interventions to address that cold problem. A lot of it is around improving housing quality. So in terms of current management of their risks, most investment is around cold, which is as it should be, because that's a bigger burden. But there is an acknowledged reduction in these cold-related deaths going forward. We know this. And in countries in temperate populations or temperate areas, then the cold will still predominate even to the end of the century because it's so large. But because populations are aging, some of that benefit is offset by an aging population. Okay, so the benefit's never as big as people thought it might be. And then the question is, what do you do differently in this reduction in cold? And the answer is absolutely nothing at this point, because we still need to prevent all these cold deaths. There's not a kind of opportunity to exploit here, because we're asked, in the risk assessment, to look at the benefits and opportunities. And I actually spent a lot of time explaining why this was a benefit but not an opportunity, because there needs to be no additional government action, because they're already, well, you could argue they're not managing cold as well, because you still have a cold burden, but there's no different policies they should do because of the climate change, I guess. It's that long-winded thing. So the basic thing is we still have to manage heat and we still have to manage cold, but it will vary by different countries. And then there's the kind of catastrophic failure of the Gulf Stream, in which case we'll get a hell of a lot colder, and that would be pretty awful. but we don't know anything, we can't manage for that either. So
no. And, you know, we saw a presentation recently that was suggesting that in the US that many physicians aren't, particularly even in emergency rooms, aren't really on guard for thinking about heat stress, particularly in parts of the country where it hasn't historically been an active source of mortality. Is that an issue in the UK? Is that changing? What's your perception on that?
No, I think the UK, because we do have a fairly moderate climate, we don't have heat waves. Having just had 3 though, it might be different, but yeah, I don't think we're generally prepared for heat. But we're also not generally prepared for cold. You know, every time it snows, the country stops anything. So, but you know, they're an obvious target emergency room, you know, or A&E as we would call them, about surge. But there's, you know, so we know there is an issue around managing surges. So the question is then, would an alert system help managing that? And I think it does, you know, clearly that's where your cascaded messages should go about people managing resources within the emergency department. But yeah, so the only information we have is this in-depth survey that was done within that evaluation in 2019. And in that, the knowledge in the frontline staff was still relatively low.
Right, right. So we have another question about the floods aspect, and they're wondering what sort of public insurance programs are there available to help flood victims in the UK?
That's a good question, because we actually did a review of all these different interventions or flood responses, of which insurance is one, to see whether they looked at who benefited and who didn't, or who did the uptake. And in fact, insurance is the one where there is a differential in uptake. You know, a lot of poor households don't take up the insurance. So we know that that's a problem. Now we had an insurance thing called Flood Re, which is a kind of reassurance system, but I'm not experienced enough to describe it, but it is being phased out. Okay, so the public insurance that we had, or the subsidized insurance that we had, is about to discontinue. So there's a lot of concern for when that stops. Okay,
Absolutely.
so whatever problem we have now is going to be much worse when Flood Re removes. And we've got so there is a lot of work now being done at mapping about who has insurance and who doesn't, but there's no specific policy mechanisms to address this, I think, at the moment.
And realizing you're not an expert on this, but is it being removed because of the cost? Why are they getting rid of subsidized flood insurance?
I don't know, to be honest. It's not my area.
It's a hot potato in the US right now politically.
Okay,
because it's going to be so expensive, and the issue is who pays. But
absolutely.
Yeah. So I think, I mean, some of the work you showed around flooding and mental health, it was pretty interesting to see those data, particularly the outcomes and how long lasting they were. Were you surprised at all by those results? I mean, sort of the multi-year effect?
Yeah, I think we were, and we but the study was specifically set up. I mean, we had obviously a drop off in the cohort, so to speak, but yeah, we were quite surprised that they were still quite high, and the rates, you know, were pretty high. But yeah, but there's also, so as well as the kind of, I mentioned how that information is put into kind of high level decision making, there's obviously a lot of work around, you know, the mental health sort of response on the ground. And so I think a lot of that has improved as well to deal with, you know, the longer term health impacts and making resources available.
Yeah, that makes sense. And I was also curious, you know, you talked about sort of the 3 ways of prioritizing, you know, current and future effort around the low, no regret actions that we could take now, the factors or decisions we might make that would lock us in, and then these sort of preparing for stuff with long lead times. What were you thinking about, or what's being thought about the long lead times? Is that new infrastructure for flooding, or what sort of things come to mind? Can you give us some examples there?
Well, not so much. You're right. Most of them are outside the kind of public health remit. They're looking at infrastructure and energy systems and kind of resilience within. I mean, the issue we've got in our chapter was around communities and coastal change. So when communities have to move, so we have a risk around the viability of communities, because this is one of the issues that I mentioned. There was a lack of governance, so there was no there weren't really mechanisms for communities to start engaging and discussing about what their options were. Now there are things called sustainable or shoreline management plans, within which communities are supposed to engage around their long-term planning and viability. And it's still relatively, the numbers are small. I mean, compared to the problems you probably have in the US, they're very small. They get a few villages, not at the moment. But those decisions need to be started now. Those discussions need to be started now. That you can't leave them until the last minute. But they need to be done very carefully, because you can't, don't want to. There's harms. You don't want to blight an area, for example. So I think a lot of progress has been made in trying to set up the mechanisms to address some of these issues. So that's probably the best example.
No, that's good.
Other than the housing, building houses and building hospitals and building schools that don't overheat.
Absolutely. So, cognizant of the time, I'm going to ask, there's one more question from the Q&A I want to ask you. And it says, what is the impact, if any, of climate change deniers on public health initiatives in the UK? What can public health agencies do to address those?
We don't have those anymore.
Isn't that wonderful?
Well, they don't deny climate change anymore. They just say, "Oh, that's really expensive. Let's not do that." The argument has changed, hasn't it? Or so we don't have that problem. I mean, we obviously do have the problem. I mean, a lot of the problems are old problems around public health. We've always had problems trying to get health issues in other sectors. That's why we're not managing our air quality as well as we should. So climate change, in a way, is just a new topic with an old problem. So a lot of the barriers and mechanisms around, making change or making the health argument kind of remain. So I wouldn't say that kind of climate change skepticism per se. In fact, a lot of it is actually a lever, because people are interested in it and they want to do stuff. So it's actually a way of opening doors rather than closing them. But then I don't talk to loads of people, and everybody I talk to is kind of very worried about climate change. So I probably give quite a biased view. You see what I mean?
I'd be curious, but presumably it is a larger issue in the US, where there's a very active and well-funded, well-orchestrated climate misinformation campaign that people actually at Brown and around the world are studying. There's something called the Climate Social Science Network that got set up last year that's really aiming to understand how these sorts of systems work and what can be done about it. But look, I want to thank you for, that was just a fascinating talk. Thanks so much for joining us today. And especially late in the afternoon, or it must be early evening, I guess.
It's not too bad.
Not too bad. Okay, good. Well, thanks so much. Have a wonderful evening.
Thank you.
We look forward to interacting with you in the future.
Okay. Thank you very much.
Take care.
Bye.
Bye, everyone.